Welcome, everybody. Welcome to Mr. G's Kitchen. That's where I'm coming to you from to record this particular chapter. It's looking like I'm going to have to re-record chapter 19. I spent over 40 minutes today recording that for you, and I'm trying to watch it back now, and I have no audio, so awesome times. But we will continue on and see what's what. So here's a little bit on chronic health conditions and physical or functional limitations. Now, look. We're at the end of the course right now, and a lot of this is better understood by going into your book and delving in deeper. Again, this is one of those things where we have entire courses dedicated to it. NASM is just trying to give you an introduction to some special populations. That's the word we probably would use that are involved with some of this. So it gives you an idea as to some of the specific limitations to look for. Here's the thing, when it comes to taking this test, the NASM exam, you need to know what's in these chapters and be able to answer these kinds of questions. But in the real world, when it comes to special populations, you don't need to memorize every single modification or thing that you should and shouldn't do for every single condition there is out there. But what you do need to know how to do is how to go to your resources like this book, like this chapter, and like some of the other books that you'll get, and find out what you can and can't do and what you should and shouldn't do with these clients. That's why we have assessments. That's why we go through the Part Q, the HHQ, and that kind of stuff so that we can figure out what is best for our clients so we don't do anything that's going to hurt them. We know what those contraindications are and we use them. So we are going to go through Chapter 16. Here we go. Now we'll define them all. Age. So let's look at age first because being elderly or being young are both special populations that we are going to be able to work with. So as you probably are aware, there are some physiologic differences between being a child and being an adult. Instead of children have a peak oxygen uptake instead of a VO2 max. Children are less efficient and exercise at a higher intensity than their maximum VO2. So they can actually go a little beyond what you might think that they can. But here's the thing. Children do not produce enough glycolytic enzymes to perform sustained high-intensity exercise. Their bodies aren't mature enough to run that way. Children are also not as efficient at thermoregulation, so they're not good at maintaining their body temperature. They can overheat or they can get too cold too quickly. Not everything has matured enough for them to do everything the same way that adults do. So when you train kids, it's not just a scaled down version of what you would do with an adult. It has its own unique challenges and own unique considerations that you need to be aware of. So strength training for kids, resistance training. Believe it or not, lower risk of injury than most sports in which youth commonly participate. So you're not going to hurt somebody if you actually do some resistance training with them. The most common injuries are sprains to ligaments and muscle strains, all right? And those might probably come more from sport. Children will build strength and bone density, but they're not going to see a huge increase in muscle mass. They're not producing the hormones. It doesn't work that way. It's the same thing like when women talk about not wanting to lift weights because they don't want to get too big. Unless you have help and you've got hormones that are going to get you there, you're not going to. You're not going to build tons of muscle. It's the same thing with little kids. Even if they work out hard, they're not going to get tons of muscle mass. They'll be healthy, strong little kids. So it is a good thing, and don't let anybody tell you differently. Here you see some basic exercise guidelines. I'm not going to read it all to you, but take a look at it. And here's some things that really are kind of striking. I was actually having a conversation with my wife earlier today because my kids are playing outside for a while and they like to go do that. And fortunately, we live in a neighborhood where there's lots of kids and they all go outside. They're not just glued to their screens. So take a look. Some basic guidelines for kids. They can do pretty much anything. Walk, jog, run, games, activities, sports, you name it. 5 to 7 days a week. That's how often they should be active. And we're talking moderate to vigorous cardiorespiratory exercise training. So that doesn't mean like running and running and running. It just means go out and play hide and seek with your friends. And usually they're going to do that for some time. 60 minutes per day. That is the recommended duration that kids should be getting for their activity. Do you know a lot of kids like that? I know some of you are parents. Ask yourself honestly. My kids don't get it every day, but I'm so grateful. That was the conversation my wife and I had earlier tonight. So grateful that we live in a neighborhood where they can go out and play, and there's other kids that do it too, and parents are supportive. It's the best thing for them, and it's good to keep your kids healthy. You can do some different assessments. You see them there. Flexibility is there as well. But from resistance training, they tell you, looking at phase 1 of the OPT model, phases 2 through 5 are maybe a little bit more appropriate for later on with kids, but it's really just about moving them. Special considerations, progressions for youth population should be based on postural issues and the amount of weight that can be used. So just make it fun for them. If kids are having fun, they're going to be active, and being active is going to lead to healthier bodies in childhood and adulthood. It's all good. So these are pretty simple. You can see more specific recommendations here. And if you ever had kids, like you, this is where you go to this chapter, you look at this, and you pick some things out. On the other end of the spectrum, so we talked little kids. Now let's talk senior adults. We live in Florida, so there's a whole lot of these folks out there. And there's a lot of considerations we need to keep in mind for them. Lots of physiology changes. Those can create some challenges. Chronic diseases like arteriosclerosis, atherosclerosis, peripheral artery disease. These are all things that can hamper exercise, and they can increase caution. And if someone is overly cautious, they're not going to move confidently. They're not going to move well. It might open them up for injury. So there's lots of stuff that old people need to be concerned with. Some normal physiologic and functional changes that are associated with aging include reductions in some of the following areas. Your max heart rate. We know 220 minus your age. Every year we get older, our max heart rate decreases. So when you turn 50, 60, 70, 80, you can see that's 10 beats per minute that you should be a little bit lower for your max. So you can't work quite as hard. Cardiac output. So that's stroke volume times how much, your beats per minute. Muscle mass, that decreases with age. Balance and coordination, so that neuromuscular efficiency, that starts to go by the wayside. Connective tissue elasticity, bone mineral density. Your bones actually get more brittle, they get thinner. But here's the good news, everybody. A lot of this stuff, with maybe the exception of maximal attainable heart rate, this can all be improved by consistent exercise, good lifestyle habits. Here are some of the guidelines for older folks. You can see it looks a lot like what you might see for an adult. You also see maybe for like mode of cardio training, which is that top part of this table, stationary or recumbent cycling, aquatic exercise, treadmill with handrail support. These are all things to kind of look into some of those balance issues we talked about, maybe minimize some of the impact on their joints. So those are some of the choices there. 3 to 5 days a week, 3 days per week of vigorous intensity activities. That's the same as for regular adults. Phase 1 of the OPT model, and then phases 2 through 5 is really based on how capable they are and how much a doctor has cleared them for. Progressions should be slow, well monitored based on postural control. Exercise should be progressed if possible towards free sitting, so no support or standing. Again, a lot of people that are going to be coming to you, they're not going to be these really super able-bodied, super fit seniors. You're going to get people that have degraded to a point where they're looking to make changes. So you've got to make sure you progress very slowly and get them back to what you would consider functional for most adults. And that's, free sitting, free standing, things we take for granted right now. A lot of older adults cannot do. So we want to reestablish that. Yeah, so take a look at some of these. Again, I'm not going to read all of these to you. Each condition we talk about is going to break down these guidelines. We'll kind of look at some unique ones about each and move on from there. Obesity, another big one. Fastest growing health problem in America. Approximately 66%. That's pretty close to 2/3. People older than age 20 are overweight, and of those, 34% are considered considered obese. And again, we usually use BMI, which is just a measurement of height to weight ratio. So that doesn't take into account actual body composition, so fat mass versus lean mass, but still, it tells us something. It tells us that we are bigger for our height than we should be. Those are the ranges that are considered normal, overweight, and obese. You should know those already. They come up in tons of classes. We don't need to spend time on it. But obesity is complex in cause, and it can really affect you in a number of different ways. Like, yes, as we get older, it's natural to put on a little bit more fat and lose a little bit more lean mass, but there's also a lot of lifestyle factors that need to be considered too. Age is not the only one. So for people that are obese, you're probably going to stick to phase 1 and phase 2. From all the work we've been doing thus far, that probably should not surprise you. The goal really is going to be losing some of that weight, because then you can start actually getting more functional. Slow, gradual weight loss through decreased daily caloric intake. So just don't eat as much and burn a little more. That's really what it's going to do. You do that through giving them cardio and strength training exercise. Burn more calories and take in less calories. There you have it. Low impact stuff, 5 days a week. Again, normal adults, stage 1 cardiorespiratory. Again, long periods of time, 40 to 60 minutes a day, or you can do 20 to 30 minute sessions 2 times each day. Look, if the goal is weight loss here, that doesn't happen without lots of focused effort. So yeah, they're going to be spending quite a bit of time working. And then when it comes to some of the other more traditional parts of the OPT model, you see some of the assessments they give there: push, pull, and squat tests, a single leg balance test if tolerated. Again, depending on how obese your client is, you might not be able to go that far. Again, SMR only if it's comfortable. Go along the flexibility continuum, see what they are capable of. And then you see some resistance training guidelines. Some special considerations here for the obese population: make sure that the client is comfortable, be aware of positions and locations of the facility that your client is in. Things even as simple as like the bench press. If you're somebody that's pretty obese, a bench is only this wide. And even our backs, as or people that are not severely morbidly obese, are wider. If you have someone that's really big, they're going to be pouring off of this bench, and that's not a comfortable situation. It's not me making fun of anybody, but it's probably not the best position to have somebody in. So you may want to analyze what you're doing, when, where, how, and pick the best things possible for them. They should actually be doing things in a seated or standing position, because again, more functional, it's going to be better for them. And when you are obese, you also are at risk for other chronic conditions. And if that's the case, you definitely want to make sure that you've got those doctor's notices and release forms as well. Diabetes. 2 types, type 1, type 2. 7th leading cause of death in the United States, believe it or not. 23.6 million children have type 1 diabetes. And look, not a whole lot we can do about that. That is, you're born with it. That's what you got. It's unfortunate, but it's manageable, and you can live a relatively normal life. When it comes to what we do for type 2 diabetes, we can help to improve it by decreasing the amount of insulin required and increasing insulin sensitivity. So that's good. We can regulate our blood sugar levels. We don't have to convert as much to fat. Like, this is a better thing to happen. So exercise is medicine. It's good. It can help alleviate some of the unfortunate symptoms of type 2 diabetes. Type 1, where you're not producing insulin, exercise isn't going to help with that. There you see it. Some special considerations. We'll go to that. You can read the rest of this on your own. Make sure your client has appropriate footwear, because again, usually there are issues with the feet when it comes for blisters or abnormal wear patterns. That's something that doctors should keep an eye on. Advise the client or class participant to keep a snack, so a quick source of carbohydrates, so some quick sugar available during exercise to avoid sudden hypoglycemia. So if they don't have, and if their blood sugar drops, which can happen to diabetics while they're in the middle of a workout session, you want to make sure that you have something on hand. And it's better if they provide it, because if you have something and if you don't know if they have allergies and you give it to them, then you're opening yourself up for more issues than you probably really want to. Use SMR with special care and a licensed physician's advice, so you can't just go to work like you normally would. And then avoid excessive plyometric and higher intensity training is not typically advised for most clients that are diabetics. And you're not using kid gloves here, but there are some considerations you need to be aware of because you don't want to worsen any of their symptoms. High blood pressure, hypertension. Now, stick with the numbers that are here in NASM. I know that recently we've heard stuff from doctors that say that this has changed. Hypertension now being classified at 130 over 90 as opposed to 140. Put that out of your head as far as this is concerned. I'm sure that the information will be updated in the future, but for right now, let's stick with the old numbers. Hypertension is classified at greater than 140 when on the systolic and greater than or equal to 90 on the diastolic. Research has shown that exercise can have a pretty noticeable impact, modest impact on lowering high blood pressure by an average of about 10 millimeters of mercury. So that 140, that's in millimeters of mercury. So taking it down by 10 could bring you down to 130 for both systolic and diastolic. So you can have benefits to both. Resistance training should be performed in a seated or standing position for those with hypertension. Phases 1 and 2 are going to be considered the most appropriate. Here are some things to look at for special considerations. Avoid heavy lifting and Valsalva maneuvers. Again, those are things that can really spike the blood pressure. You don't want to do that. Valsalva maneuver is when you're not breathing, when you're kind of pushing out the air but keeping your mouth closed and nothing is coming out. It's a common technique that power lifters will use where they're not trying to release any of the air as they're kind of pushing through a really heavy lift. It's something that a lot of people will just kind of naturally do rather than getting in oxygen and using it. You want to avoid this in particular for for clients with hypertension. If it goes too high, you're looking at trouble. Don't let them overgrip weights or clench their fists when training. Again, these are all things that can spike it even more. Modify your tempo to avoid extended isometric and concentric muscle action, so keep those phases a little shorter. Perform exercise in a standing or seated position. Allow client to stand up slowly to avoid possible dizziness, and go through your progressions to these workouts nice and slow. Let the body get used to what it's doing. Number one killer here, leading cause of death, disability for both men and women. We're talking coronary heart disease. There's been a significant reduction in death rates from this between 96 and 2006, but still it's number one. Resistance training, seated or standing, phase 1 and 2. People with stable coronary artery disease should know or be taught information on the importance and benefits of exercise. So even if they've got it already, if it's manageable, there are still quite a few benefits that can help improve quality of life and maybe even lengthen the duration of life. There you see it. Look at the intensity for cardio here. This one's kind of interesting where we look at specifically the talk test being used because medications might affect heart rate and you're only working in stage 1 cardio. If you forget what that is, you can always go back in your books, go back to the cardio chapter where we kind of look at what the target heart rate range is there and what makes sense. 5 to 10 minutes warm up, cool down. Short exercise session, 20 to 40 minutes, followed by 5 to 10 minute cool down. Again, very similar to what you do with normal adults. But again, there's just special considerations, which in this case, look at to see if they have any other diseases. Because typically if you got one, you might have others. They're usually a high comorbidity rate. That's the word, where it kind of happens along with other particular chronic diseases. Tempo here again, no Valsalva maneuver, no excessive isometric or concentric muscle actions, heavy lifting, don't let them overgrip the weights, perform exercises only in a standing or seated position, don't have them lying down, and progress nice and slow. Kind of similar to what we were looking at before with hypertension. Osteoporosis. Osteoporosis is a condition where people's bone mineral density, so the density of their bones, how strong their bones are, it's lower than normal, and that's considered we're talking osteopenia first. Osteopenia is that precursor. So it's still lower, but it's not full-blown osteoporosis. But still, it's of pretty significant concern because if you have it, you're walking right towards full-blown osteoporosis, where that bone mineral density gets very brittle, and then it's very easy to break everything in your body. Osteoporosis, significantly reduced. Research has shown that the risk of hip fractures doubles every 5 years in postmenopausal women older than, and I can't see what the number is there, but as you get older, it's something that you have to worry about. And I've said this before in other classes, if you're newer, women are much more at risk than men. It's hormonally tied, especially once they get through menopause and the hormone situation is different than what it was before. That bone mineral density starts to really decrease year after year. So you got to be mindful of that. Phase 1 and 2, OPT model, are good phases to train in. Flexibility, limited to static and active stretching. Submyofascial release might not be good because, again, think about how much weight and pressure you're putting on not just your muscles in order to kind of get those trigger points, but think about what you're doing to the bones that are immediately underneath them. Somebody with osteoporosis, I don't know if that's such a good idea. Focus on load-bearing exercise, but use caution. So anything load-bearing, so standing up, or even any resistance exercises are good, but don't go too crazy because that stuff under there, the bone is not as strong as it used to be. It can break. There you go. They give you some treadmill with handrail support. They actually make different types of treadmills. Ones with softer decks or ones with harder decks for different populations. So if you go to like a senior citizen center and they've got treadmills, they probably have the decks on the deck is like what you run on, what the belt runs along. More forgiving, a little bit easier for that population. Progressions in the resistance training, slow, well monitored, based on how well they can get around. Free sitting or standing is really what you're aiming for if they can't already do it. Focus exercise on the hips, thighs, back, and arms. All areas that are really super congruent with functional activity, with activities of daily living. Don't put a lot of spinal loading on the squat and leg press exercise, and make sure that they breathe normally and not use any Valsalva maneuver. Not good for those with osteoporosis. Arthritis, inflammatory condition that mainly affects the joints of the body. It's a leading cause of disability among U.S. adults. So there you go. There's a fun fact for you. Osteoarthritis is caused by degeneration of cartilage within the joints. Rheumatoid arthritis, which is different, that's a degenerative joint disease in which the body's immune system mistakenly attacks its own tissue. So it's not the same as your osteoarthritis. Rheumatoid arthritis, it's a degenerative joint disease. Clients with it have a decrease in strength and proprioception, also have loss of knee extensor strength in some cases. Symptoms of arthritis like joint pain and stiffness are heightened through inactivity as a result of muscle atrophy and lack of tissue flexibility. So even though it hurts to move these joints, if you don't move them, they're going to hurt worse for the reasons we're talking. Your muscles are getting weaker, so now they hurt when you do stuff. And all that connective tissue, that's going to have some issues as well. Functional capacity and balance can be increased by progressing exercise so they are performed in the seated position without support or a standing position. Are you getting the theme here when it comes to special populations? A lot of this is just starting very low level, working your way up progressively, appropriately, so that they can just do things normally, sitting unsupported or standing up. Things, again, that we can all kind of get up and easily do, but folks with all of these different chronic conditions, it's not that simple for them. There you see it. There are some examples of what to do. Cancer. You don't usually hear a lot about training with cancer, but it's the second leading cause of death in the United States after cardiovascular disease, with more than 500,000 deaths annually. Most people have been affected by cancer in some way, shape, or form, either whether it's themselves or their family. So it's a big problem. It's been estimated that American men have about a 44% probability, and women have a 38% probability of developing cancer during their lifetime. I don't know about you, but you read that statistic, that's scary. Any guys that are watching this, that means almost 50% of us, like 1 out of every 2. Think about the amount of people in our room, in our classroom this month. Half of us are likely to develop cancer. That's a wild statistic. And for women, that's over a third, 1 out of every 3. Scary stuff. So exercise is an important intervention for clients that are recovering from cancer. It does a couple of different things. It can actually improve exercise tolerance, reduces some of the cellular risks associated with cancer, and exercise, as you know, it does release a lot of feel-good hormones. It can improve your quality of life and give you a more positive attitude. I know that's not something that's in here, but I'm a really big believer in that. If you have the right attitude and you've got a good head on your shoulders and you believe positively, things do come to you. Things are attracted to you through the kind of attitude that you have. And exercise is a great mood enhancer. If you feel better about that and what you're doing and moving, you're going to have a stronger mind, stronger body, stronger immune system. I'm not going to say that that's the be-all, end-all that's going to help cure cancer, but I certainly know that it's not going to hurt you either. There you go, some basic guidelines there. They can do pretty much whatever they want. Good rest intervals and progress them slowly. If SMR is tolerated, do it. If not, you may not want to use it for anybody that's undergoing chemotherapy or radiation treatments. There may be a need to start with only 5 minutes of exercise and progressively increase depending on the severity and conditions of fatigue. Again, a lot of the treatments for cancer are pretty invasive, so you're not going to be able to do a whole lot, but something is better than nothing, and it's great to start small. Pregnancy. Yes, this is considered a special population. No, it's not considered a disease like the rest of what we have. There has been a lot of research out there that shows that exercising while pregnant is a good thing. It's good on the physiology and health of the mother and the developing baby. Gradual growth of the fetus can alter the posture of pregnant women because, again, all the center of gravity is going to shift forward because there's a lot more weight in the front. That makes flexibility and core training important. You see a lot of excessive lordosis in women that are pregnant because, again, all that weight is here and it's going to pull you down into that anterior pelvic tilt that we see just kind of naturally from sitting. Now you put a big, bowling ball, you have a baby sticking out in front of you, you're going to exacerbate it more. And then rather than working the hip flexors and stretching those out and making sure everything is nice and tight as opposed to lengthened in the back, like your glutes and hamstrings, what women typically do that are pregnant is they arch their low back. They go into that lordosis. And then a lot of pregnant women suffer with sciatica. This is a result of lots of postural issues. It's also good for women that are pregnant to work pelvic floor musculature. So like those Kegel exercises, that is actually a beneficial thing to do as well to kind of help along with delivery, recovery, all that stuff. And care should be taken in the postpartum period as well, because again, hormonal changes are going on. The body is kind of readjusting to itself without growing this new life. It's a really interesting, amazing phase to go through. I know some of you ladies have had babies, so you understand. I fortunately have, as a father, I've gotten to experience it, especially with my wife when our daughter was born. She exercised very frequently, and you know what? My wife has had 3 children, and she said it. She was the most active when she was with me for our daughter, and she said it was the easiest delivery she had. And even with a cesarean section, because she was so active and because she did so much during her pregnancy and throughout, even with that, where muscle and tissue are cut through in order to remove a child, she was able to get cleared in very quick time within just a few weeks, and she was back to running, doing all kinds of great stuff. So exercise is really, really beneficial. There you see it. I mean, really, it's all about not doing a lot of jarring motions. And with exercise in pregnancy, if you're already doing it when you start, it's okay to keep doing it. A lot of the problems arise when women get pregnant and then all of a sudden they want to now adopt this new exercise mentality where they do lots. Now, you should be active and you can adopt a new exercise program, but you probably hear a lot of arguments about CrossFit for pregnant women. Well, CrossFit's fine for women that do it before they're pregnant. I don't think I would recommend picking it up while you're pregnant for the first time. I think then you're setting yourself up for some risk that's unnecessary, because you're growing a life inside of you. You can't tell anybody anything that you want to do, but if you're training somebody and they're kind of putting you in a place where you feel uncomfortable, that's your professional call to make. I know how I would react, so that's just kind of my 2 cents there. No SMR on varicose veins and areas of swelling. Plyometric training is not advised in the 2nd and 3rd trimesters, but again, if somebody's been doing them all along and they can safely perform them, okay. But again, think about even our box jumps. If somebody falls even one time, a violent fall, I don't know, and then we know postural changes occur, there's joint laxity. Look, it's not a disease, but there are some physiological changes that do need to be accounted for. Just exercise safely, know your body, talk to your doctor. Don't overdo it if you weren't overdoing it before, but if it's something that you're comfortable with and something that you've worked with, it's perfectly fine to keep going. Lung diseases. Lung tissue can be fibrotic and thus dysfunctional. Airflow is restricted. Clients that have lung disease are often short of breath. That's the term known as dyspnea. That comes up in some of our other classes too. Fatigue at low levels of exercise. So even though it might not seem that hard, if they are short of breath and they can't get enough oxygen, they're going to get fatigued sooner and earlier. Exercise can improve functional capacity and decrease the symptoms of dyspnea. And in some clients, inspiratory muscle training can specifically improve the work associated with breathing. There you see, for someone with lung disease, some of the guidelines. Again, you don't need to memorize all of this for everybody, but it's here, okay? Just know some of the basics for now. But if you're going to take this exam, learn a little more. But when you go into some of the more of the courses that we actually have, you'll be much more familiar with each and every one of these chronic conditions. We're not going to just jam through them in one PowerPoint and one chapter. We have an entire book dedicated to each and every one of these issues and more. There's vascular issues, peripheral arterial disease. I'm just going to kind of adhere. I'm going to go to this last little point right here. If you've got someone with PAD, before we even talk about any of this other stuff, they've just got to go to a doctor. So there you have it. Physician clearance is going to be necessary. Lots of rest in between, only 5 to 10 minutes at first, and then progress your way up. So that is a very basic, very stripped down version of talking about special populations. It is one of the objectives in this course. I think it's like objective 3 or 4. I don't have that in front of me, but it is something that we needed to cover this month. So here is my effort to do so. Stay tuned. You're going to definitely want to check out Chapter 19. Trust me, there's stuff in there that will benefit you, and not just for the sake of your own knowledge. So a little sneak preview of things to come. Thanks very much, guys. Hopefully you understand a little bit more about what to do for people with special needs. You want to make sure you give them the right amount of safety because of their condition, but you also want them to benefit and improve. And that's what this was all about here. Thanks, guys. Hope you enjoyed it.